people don't want to stop talking with each other, which is just beautiful, because what we're trying to do is, and we have done, is to create a community of people who are working together, everyone bringing their perspective on how do we improve clinical outcomes. So we have a wonderful program today, which Dr. Carol Zaher will be introducing in a few minutes. I just wanted to give a quick update about our wonderful opportunity at the Centers for Disease Control in Atlanta. Earlier in September, Betsy Thompson, the head of cardiovascular disease for the Centers for Disease Control, flew me back and some of our leaders. So from left to right, you have Dr. Jose Arevalo, who is my founding co-chair for our Sacramento Capital Region University Best Practices. Next to him is Bill Baumer with the American College of Cardiology and UC Davis Cardiology, who chairs our Sacramento group now. Then you see me smiling like a Cheshire cat there. I'm so happy to be there. Then you have Betsy Thompson, who had been involved with our Sacramento group when she was the head of Region 9 for HHS in San Francisco for the nation. Now she's been promoted to be an admiral in the public health service and to lead cardiovascular disease for CDC, as well as being the Assistant Surgeon General. Then you have quite a few familiar faces here. Dr. Keith Emmons, who's in England right now. He's the head of our heart failure work group. And to his right is my former co-chair for our San Diego University Best Practices, Dr. Scott Flynn with Blue Shield, formerly with the Navy SEALs. And then we have our wonderful Dr. Steve Chen, who will be presenting in a little while. So we had quite a contingent there with us at CDC, including our LA leadership. Steve Chen has been an amazing, quiet and effective leader over many years. I first met him in 2009 when he just sort of pulled a double backflip, triple, amazing out of the ballpark session here at RAND, where he presented information about pharmacists on the care team and brought in deans from all the schools of pharmacy from around the state, and I brought in a lot of medical directors from the health plans, and that resulted in some famous commitments that have evolved into, in many places now, adding the pharmacist to the care team. What we have seen is that it takes a long time for that which is in research to be implemented in reality. So what we're essentially trying to do in the University of Best Practices is speed the implementation of what we know works to improve outcomes. So it was a wonderful honor to be there at CDC with some of our leadership. Betsy Thompson sent me an email in July and said, Hattie, I'd like to fly you back to this 2-day, 100-person invitation-only meeting. And by the way, who would you like to bring with you? And I, in addition to the group in the photo, we also had with us Dr. Oliver Brooks, who's the president of the National Medical Association and also the chief medical officer for Watts Healthcare. And we also had the wonderful Carol Watson, who many of you have heard speak here, amazing cardiologist from UCLA. But they weren't able to stay long enough to get in the photo at the conclusion of the meeting. They had to fly back a bit early. So with that, why don't we go around the room, just say our name and organization, and then we'll have Carol kick off the formal part of the meeting. Just how about if we start with Earl, since we're going to have formal introductions of these two momentarily. And everyone knows Dr. Carol Zaher, cardiologist, with HealthNet, our longtime chair for Los Angeles.
Yes, hi, I'm Earl So. I'm the medical director at the downtown LA VA clinic.
Hi, I'm Hong Wen, and I'm a district manager for the Ralph's Grocery Company.
Hi, I'm Anna Madrid. I'm a fourth-year medical student at Keck School of Medicine.
Cameron Beckler, also fourth-year medical student at Keck.
And can you just speak up?
Sure, Joanne Nguyen, medical advisor from Boehringer Ingelheim.
Hi, Elisa Stomsky. I'm a quality improvement specialist with HealthNet.
Hi, I'm Amanda Calvert, and I'm a Medicare STARS Clinical Program Manager for Blue Shield of California.
I'm Jennifer Kwan. I do research and special projects at USC School of Pharmacy.
I'm Maria Romero. I am the Quality Improvement Coordinator at California Rights Meds at USC.
Hi, I'm Rupal Shah. I'm a managed care pharmacist at UCLA.
Hi, I'm Dr. Jean Shadadpuri. I'm VP Medical Affairs at Cinti.
Donna Lieberman, Corporate Development Officer with the American Diabetes Association.
Kimberly Kevelbeck, over health systems for Noah Nordisk, and a nurse.
Hi, good afternoon. Jim Gerson, Regional Medical Director with Blue Shield.
Phil Kaufman, Chief Medical Officer, Canary Health.
Bob Trine with Trine Consulting and serving as the Regional LA Director for the University Best Practice, working with Hattie and California RightCare.
Well, welcome everybody. It's nice to see some new faces, and it's great to see some medical students. So we're starting our efforts early in the training process. I think that's wonderful. So bring some more of your friends and even relatives next time. I'd like to welcome everybody. We do have some new faces, which is great to see. The LA University Best Practices does seem to have somewhat of a revolving membership that comes and goes, and you'll see different people periodically. And that's great to have an infusion of new folks to help complete our mission of reducing cardiovascular adverse outcomes. I'd like to also thank RAND for allowing us to take this beautiful location and hopefully convenient to those of you who have to travel midday. But it's really a wonderful venue. And I do appreciate the effort that you all do come here, because I realize LA traffic isn't the best. We try to hold it in the middle of the day, but then that does impact your workloads and how you respond to your typical daily duties. So just to let you know, we really do appreciate your coming and participating. And I also want to say we really appreciate Hattie, who's been tireless and working so long at this effort to really keep us going. So thank you, Hattie. So that said, I'd like to introduce our first speaker, who's been slightly semi-introduced by Hattie. Steve Chen, who has been with us for a long time and has been stalwart in efforts to really integrate the pharmacist into what we do in care management for patients. And so I'm really looking forward to this topic. You can see his long list of accolades there. I'm not going to take time out of his presentation to go over them, but they are impressive. So Steve, thank you. You're up.
Thank you for being here. I really appreciate the time to share this work. I'm really excited about it. Hattie asked me to give a few words about a program that we are partnering with the LA County Department of Public Health, which is part of a CDC 1817 Wellness Grant. It ties together work we're doing at the USC School of Pharmacy, work at the medical school at USC with the GARE Center, the Barbra Based Hypertension Project over at Cedars-Sinai, and of course the RightCare initiative here in LA. So we're really excited to share this piece of it. So this is one piece of this big program, and I think we're trying to con Tony Kuo into coming and sharing the big picture of it all in a few months, right? That's one of our goals. But I was asked to share at least this piece of it, because I think you'll find that it does align very much with what we're trying to accomplish through RightCare. So the California Right Meds Collaborative, what it is, how it works, what's it based on, what makes it unique is what I'm going to cover in about 20 minutes or so. I won't take too much time from what I think is going to be a fantastic program for Dr. Minissian. So for good background, I think I'd level set it maybe more for students and everyone in the room that's lived this so long. we have all kinds of mergers going on in healthcare involving pharmacy, PBMs, health plans, and this is just a sample of what you're seeing changing in the landscape. Kind of exciting. I think for many pharmacists, it's a little nerve-wracking, trying to figure out what the future of pharmacy holds. And I look at it as there's some tremendous opportunity here. I mean, for example, take a look at the first one, Cbs and Aetna Merging. It really puts CVS in a tremendous opportunity to improve population health outcomes for the Aetna population. Pharmacists can be doing so much more out of community pharmacies like they do in integrated health systems. We're not quite seeing that happen yet, but we think that potential is there. But it does represent a threat to kind of the usual type of pharmacy practices we have out there. The other threat is technology, right? If robot and computer science can deliver medication safer, faster, and more efficiently than humans, why not do it? And I think we have to admit that in the next 5 or 10 years, we're going to see a tremendous decline in what I might call the traditional roles of pharmacists in the dispensing side, the product side, and I think rightfully so. I think we need to embrace that. Because you take a look at the healthcare landscape, I think this is one of so many different depictions of what's happening, but in the next 20, 30 years, we're going to be short 120, 130, 140,000 physicians. It's a lot of physicians to be short. Right? We have a tremendously declining number of physicians, number of people going to medical school. Thank you for those that are here today, medical students. And yet we still struggle with kind of the embarrassing fact that we spend the most of any country in the world in healthcare, and we're still dead last. I think the last report I saw was 11,500 per capita, right? Yeah. Which is far. What's the next closest is maybe 8,000. So this, despite just so many gaps now in care that we're facing now, that are just getting worse. The health disparities between the insured and underinsured or uninsured. And look what we're talking about today. There's a tremendous disparity, isn't there, in women with cardiovascular disease and understanding how to manage that. So I'm really excited for the program we have today. 10,000 seniors turning 65 every day. This is an epidemic that we're not planning on for very well. As I think other countries are much more proactive. Mental health disorders, an epidemic. People didn't seem to start caring until they saw that their ability to control chronic disease is tremendously impacted by comorbid chronic conditions. And then this whole addiction crisis we have from opioids to others that nobody talks about, like meth, which is probably a bigger issue, right, in LA and other areas. All of these issues require optimal medication therapy, at least to get to a point where we can get other interventions to be effective. And we've not really figured that out yet. How do we get to that point where we can optimize medications and deal with these facts? The fact that this is costing us $528.4 billion a year, or 16% of all healthcare costs, when we don't optimize medication therapy. 3/4 of the hospitalizations are largely related to misuse of medications. Fourth leading cause of death in the U.S. is attributable to medication-related harm. And half of patients stop taking their medications for various reasons. And these are big problems that need to be fixed. And I've always argued, of course, that pharmacists are well trained to do this. We're kind of nerds for medications, and this is kind of in our backyard. And so with that background, we were thinking over the years of how do we take some of the work we've done, like for example with our CMMI grant, where we're able to show that integrated pharmacists in care for the underserved tremendously improves health quality measures, reduces hospitalizations and healthcare costs for patients at risk for readmissions. So we put together and developed this collaborative, which, as you'll see, is based on previous work that we've done, the California Right Meds Collaborative. I shamelessly stole Hattie's title. It sounds a lot like California RightCare, as you can tell. And I did it intentionally for many reasons. I think Hattie taught me a lot about how do you work with a large health system with so many different stakeholders that on one hand are competing, but on the other are facing the same mission, the same challenges. And the way that you've done this over the years, I've really admired, and I've tried to mimic some of your approaches. I can never be a Hattie Hanley, but I can at least try to mimic some of it in the pharmacy world.
We're a dynamic duo.
Okay, I'll take that. All right. So our mission is to provide optimal medication therapy for high-risk patients in their communities. It's really important. And one of the barriers that you'll hear often is patients just can't get to where they have to go to get care, especially when we talk about the underserved. So the idea is how do we get it to them? The vision is to create a network of pharmacists in the community that provide sustainable, high-impact, comprehensive medication management services that are aligned with health plan and health system population health priorities. So I think pretty straightforward. The benefits I just said, the idea of getting patients access to care, right? Not having to make it difficult for them. I think something we heard at the CDC meeting, which I really liked hearing over and over again, is make it easy to do the right thing. Make it easy for patients to get the right care that they need. Lots of challenges, let's be honest about this, right? So let's name some of them. These are challenges that I've thought about myself, or I've spoken to health plans and health systems about the concerns they have. Can any community pharmacist deliver high-value, comprehensive medication management? Simple answer is no, right? How do we make sure that we have the right network of pharmacists doing this work? Can pharmacists make clinical decisions without access to electronic health information? Okay, that's going to be a mixed answer. How will care be documented? How will quality be assured? Our collaborative manages all of these different questions. Yes?
So sorry to interrupt you at the beginning, but where you say, can any community pharmacist deliver high-quality CMM? And you said no. The capacity is there, so what do you mean by that?
What I mean is not every pharmacist wants to do CMM, right? And I think just like any aspect of healthcare, you have many of my physician colleagues who are near the end of their career. They don't want to necessarily get involved in value-based care. They want to finish out their career doing fee-for-service. So I'm just saying that there are pharmacies that may not be interested in participating, simple as that. So obviously if a pharmacy doesn't want to be engaged in providing high-value care, learning how it's delivered, learning all the process changes that are involved, participating in quality improvement, I probably don't want them in a network like this. And as a payer, why would you want to engage teams such as that? So we're being pretty selective in how this works. Now I'll explain, it's not to be restrictive, it's to make sure we have the best and high quality pharmacists that are providing these services. So the way this collaborative works, how many have participated in an Institute of Healthcare Improvement type collaborative process? Anyone? Yeah, okay, so you all know, many of you know how this works. We have our mission laid out for us. We have several expert committees. Some of you in this room are in some of those committees, and actually Blue Shield is represented on one of the committees. We have a plan committee, we have an academic committee, and we have what we call an executive leadership committee. So the idea is that you typically have, could be as small as 10, but we have hundreds of teams involved in this. And they're vetted very carefully. So what we're doing is we're mainly working with health plans to create what this looks like. Because my interest is, let's make sure the plans are happy with us and this is run in a way where they feel they're getting value from it. Because if they're not, then it's over. Why are we creating this? It doesn't make any sense. So what we have agreed upon, and I'll get to this later as to what the plans are, is the vetting process is basically 4 pieces. One is the plans look at their geography, find the hot-spotted areas where they have challenging high-risk patients being readmitted to the hospital or going to ED often. Once they develop an idea of what those areas are, there's a self-assessment survey that's provided to the pharmacies to go through a checklist of, are they prepared to deliver this kind of care? Do they have experience with it? Do they have collaborative practice arrangements with other health systems near them? Those sort of questions. Once they've gone through that survey, if it looks like they seem like a viable partner to work with, our team of CMM experts will actually go out and visit the site, sort of validate some of the questions and makes other observations to confirm that this is indeed a good site where we can send patients for comprehensive medication management. And the 4th piece is the health plans themselves look at their own internal quality data and make an assessment as to whether this is a high performance pharmacy. And I should say, when I say we, you heard before, Dr. Jennifer Kwan and Merrill, they're doing all the work.
I'm just going to make the apology. I have been asked to, by many of the health plans and others, to see if we can transmit our meetings. And we've been testing various things, WebEx, and this space may not be ideal for that. Okay. So this is what Bob Trine is experiencing right now. Apologies for the interruption.
So I did not know we were being simulcasted today. So
we aren't.
No,
We're
just
testing.
Oh, okay.
We're testing.
There are millions watching you.
Oh, that's good. Thank you. Now I don't know what to say. So typically, once we get these teams identified, we have them do a little bit of homework, and we have these live learning sessions every 6 months. Again, sorry for those that have done this before, but for those that haven't, I want to explain the process. At these live learning sessions, we have short presentations that focus on organizations or teams that have been very successful at delivering, in this case, comprehensive medication management from a variety of different venues. They talk about what they did, how they did it, what they achieved, what are the tools, what are the resources they used, how can you adopt what they've used. And throughout this meeting, as we have these quick presentations, there are opportunities for the attendees at round tables to discuss what they've heard, how they might adopt it, very much like what we do here, except we're at a big round table. And the idea is to get everybody engaged. You have, just like in this room, you have people who are experts at doing this work. So why not get them to teach the group as well, right? Have them convene, have them discuss what they just heard, have them talk about how it does or does not work for their organization, becomes really exciting because then you get, people all across the state talking about what they've been able to do. And so rather than just having a limited number of speakers share their experience and their tips, you get tips from across everyone participating. So that first learning session, live learning session, was an all-day session, November 18th. We had then an action period, and these occur between every learning session, where the teams that are on site make commitments to action. What are their next steps? And then during that time period, they're doing rapid iterative change cycles, they're doing PDSAs, trying to implement their programs. And then we have, again, learning sessions every 6 months. We just had one on September 15th, 2 Sundays ago, over here in Pasadena at the Langham Hotel. It was at least double the size of the previous ones. We kind of expected to continue to grow at that pace. Same idea, but this time we got a little more granular. The first meeting was about what does this partnership look like? What are some best practices in learning CMM? Now by learning session 2, the plan said, okay, we have a better idea as to what populations we want to drive into this collaborative. So it's starting to shape up as expensive, high-risk, heavy utilizers of acute care resources who have diabetes, hypertension, and potentially asthma as well for one of the plans. So we sort of took that focus and concentrated much of the meeting on best practices and tips for managing high-risk patients in an underserved population. So we had the same idea, I'll get to it in a second later, but some framing, some general sessions, and then some workshops that help people where they were at to advance their programs. This continues on and on until we get to the point where we can start to aggregate some results, some impact results that make the plans happy, that result in better patient outcomes, and result in a model that can be scaled up across other health plans and other pharmacies. There are monthly webinars in between the learning sessions where we take information from the plans, again, their priorities, we take information from the participants as to what their challenges are, and we come up with programming that meets those needs. We were able to hire a local coach. I'll talk about later how that was funded. This person helps with process workflow within pharmacies, with clinical consultations, just about everything. And then we have a data sharing process, which I'll talk about a little later as well, that'll enable us to aggregate clinical data and drive quality improvement by providing dashboards to the participants on a regular basis.
What a moment, right? Just look at that. So much work went into planning that, and I love that your endpoint is Congress.
Yeah, sure is.
Yeah.
That's what we're going for, right? Definitely, and certainly statewide, which I'll talk about later, we've had some challenges in legislation that relate to pharmacy. And I think part of it is they haven't seen it in action. So I think as we build this and are able to build up the evidence, it becomes pretty compelling to DHCS and the state as to why this needs to be supported.
So Steve, you and I should go up to the Capitol quite quickly because just this morning Richard Figueroa was announced as the acting head of DHCS. And do you know him?
I do.
And yes. I know him really well.
Fantastic.
He can change the
That's
world.
great.
He's done it before, and he knows us and will trust us.
So a big key to these meetings is you leave with offers, requests, and commitments, and there's an offer I'll take, so thank you for that.
And you get to know each other in ways that over time, you'll be the one sitting in the governor's office or in the Medi-Cal program or at CDC. A lot of our people are very well placed in the world, and it is through trusting relationships over, gosh, we've worked together since 2009. It started really in 2007, right. And I've been working with now the head of DHCS since 1997. So he's a dear friend, and he's brilliant. So having people of great goodwill and brains in the governor's office is a very wonderful window of opportunity to do what we've had the research on this since since decades.
It works, that's the point, right?
Yeah.
Great. Yeah, thank you, Hattie, fantastic. So I just wanted to let you know what happened at the learning session that really exciting. We always try as any meeting to frame it, get the audience excited about what we're trying to do here. So we had Dr. Tony Quill from the Department of Public Health talk about the dire needs that relate to hypertension and diabetes in LA County. He did a really nice job, very quick but powerful presentation on setting up the need. From the health plan, Nina Duong and Alex King, that's from Inland Empire Health Plan, upper right and lower left. Alex King is the clinical pharmacy director for LA Care. Gave very passionate discussions about where their priorities are as it relates to pharmacy and moving some of these measures. Nina says something that I really like. She's, as you can see, seemingly very gentle and kind, but she kind of laid the law down and said, with great power or clinical privileges comes responsibility. And she made it very clear that if you're a pharmacy participating in this program, we need to see performance in order to continue. And I agree, that's exactly what we're trying to drive. Alex, on the other hand, threw his slides away and said, I need your help with diabetes. We are terrible at diabetes. And he kept saying it about 10 different times, 10 different ways. And somehow it worked. It really clicked, and the audience got really excited about, hey, they need help with diabetes. We need to do this. And then what I love is that those are our 3 keynotes. And then Jessica Nunez-de-Ibarra, the Chief Medical Officer over at California Public Health, all of a sudden shows up behind me as I'm about to take questions. And basically she wanted to say a few things. So she took about 10-15 minutes to frame what are the changes that are happening at the state level that align with this type of work. And it was really exciting. And I think all in all, the room was buzzing after these 4 people spoke. It was a realization that the needs are clear, the plans are fully supported. We heard both plans say comprehensive medication management, as we will support it, is a medical benefit, not a pharmacy benefit. We don't hear that often, but that's the way it was framed, clearly. And again, with Jessica's description of all the very rapid changes happening in the governor's office and in DHCS, it really created hope and an opportunity in the minds of participants. Very exciting. So just very quickly, what's this based on? So you've seen this before. About a dozen years ago, we were invited to start the HRSA Patient Safety and Clinical Pharmacy Services Collaborative. This is an invitation from HRSA to help integrate pharmacists providing clinical services in safety net clinics across the nation. The vision was, as you integrate clinical pharmacy services, blue line, health status, red line improves, and green, adverse drug events are reduced.
What year was that?
That was 2006, I believe.
And this is at the FQ level?
Yes,
FQHP level?
Correct. It was the
So
FQ level.
embedded pharmacists in an FQ.
Correct, yes, I should be very clear on that. So definitely the underserved populations. And keep in mind that this is a big ask for a profession that is not recognized as healthcare providers federally, because every state scope of practice of pharmacy is wide ranging. So we learned very quickly that for the East Coast states, they can pretty much advise. They couldn't do anything like what we're doing here in California, where through collaborative practice, we can actually modify drug therapies or labs and so on. But despite that, we had pretty good results across the board, pretty exciting. Part of the tool that really helped make this work was a change package with these 5 elements. This change package is basically a map to assess where you are now in the process of being able to deliver these services and where you need to be successful. So this is a living document. It grew and grew over the course of years of this collaborative as we went along. And by 3 years, we had several hundred teams across the nation. Most states, this is actually not an accurate math, most states had teams involved in the collaborative and thousands of stakeholder partnerships that made this work. So it really took off. And kind of the bottom line, this may not be terribly impressive to you, but you think about this being an aggregate of the entire nation of patients that literally for years never got to treatment goal. By 6 months, over a third of patients with diabetes, 43% of patients with hypertension, and over a third of patients with lipid issues all were at goal in 6 months, which is, again, for this population, wasn't bad at all. Adverse drug events, potential adverse drug events both reduced. All these programs had sustaining programs after the pilot. Overall, HRSA saw as a big success. And I really enjoyed being a part of this whole process, but I realized if we do this in California, we'll get much better results. Because again, pharmacists have such greater scope of practice in the state and really decades of experience with this work.
So while most people will be able to interpret those last 2 bullet points, could you put them into sentences?
Okay, so average number of adverse drug events, actual side effects, were reduced from 0.7 to 0.5 per patient. I know it's a weird number.
What does 0.7 to 0.5 per patient mean? So
it's an average.
less than 1%.
In a given population, there were, I can't remember what the numbers were, but there might have been a certain number of side effects that were lowered across the board. So based on that number and the number of patients involved, they came out with 0.7 to 0.5.
So in other words,
30% reduction, right?
Well, thank you. In that range, yeah, you can do the math that way.
But it fell to 0.5%, it looks like.
Yes, and I think the thing that pharmacists do, well, those are actual side effects detected in the course of providing comprehensive medication management. The second bullet probably is more common, what pharmacists do and never get recognized for. That's catching the near misses, the potential adverse drug events. So these are the patients where they're getting prescribed one medication, they have comorbidities or other drugs that are a major problem, and so pharmacists are at their intersection